Hi, I'm Dr. Govind Babu. I'm a medical oncologist from Bangalore, and I'll be talking to you about the advancements that we have made in systemic therapy in advanced non-metastatic or metastatic non-small cell lung cancer. So when I started treating lung cancer patients way back some 3 decades ago, the median survival was about 4 to 6 months. But today the advances are such that we are talking about these patients surviving 4 to 6 years. So the difference is from months to years that has happened. So when we were started treating these patients earlier, we did not even have good chemotherapy drugs. What we were giving them was called best supportive care, and that gave a survival of 4 to 6 months. Then came in the platinum compounds, which increased the survival to about 8 to 12 months. So that was the first big advancement that we saw in treating these poor risk group patients of lung cancer. Then we slowly understood that the tumors produce new blood vessels, a process that we call as angiogenesis. And this the tumor does once it becomes bigger than 0.5 centimeters. And this is important to understand because for the tumor to continue to grow and spread, which is called metastasis, this neoangiogenesis is very important. And this happens because the tumor produces several substances, and one of the important one is called VEGF, or vascular endothelial growth factor. So understanding this, we developed a drug called bevacizumab, which is a monoclonal antibody that targets this molecule that the tumor produces and stops the new blood vessels being formed. So this is a therapy that is known as anti-angiogenic therapy. So adding this to chemotherapy increased the survival of these patients by another 5 to 6 months. So this was an important aspect that is now adopted in many of the metastatic tumors to block the angiogenesis that nurtures the tumor that grows and also prevents metastasis from occurring. So after this, we understood that the histology of non-small cell lung cancer is important. We classified the non-small cell lung cancer into adenocarcinomas and squamous cell carcinomas, or squamous and non-squamous cell carcinomas. And for these, we had specific chemotherapy drugs that were useful. An important drug that came in was pemetrexed, which was useful in non-squamous non-small cell lung cancer, and the other molecules, especially the taxanes and gemcitabine, along with platinum. So platinum is an important backbone for all these protocols that we use, and the histology helped us to improve and tailor the chemotherapy to some extent. With the advances in molecular biology techniques that have come in, and one of the very important ones is the next generation sequencing, which we commonly call as NGS. This has shown us that lung cancer is not just one disease, but a group of over 80 to 90 diseases put together. And many of them have what we call as driver mutations, which are important in the advancement and progression of these diseases. And this also we know that there is a difference in this different populations across the globe. And to give you an example, one of the first ones that was described was the epidermal growth factor mutant non-small cell lung cancer. And this we know is a mutation that is more common in the eastern part of this world and not so common in the western group. So in India, the incidence of this mutation is about 30 to 40%. So understanding this, there was a drug developed which we call as epidermal growth factor inhibitors. Tyrosine kinase inhibitors is a group of molecules which are tablets. So these tablets can be just taken by the patient orally. He doesn't need to get admitted. He or she doesn't need to get admitted. And patients in this, with the newer generation of these molecules, are now surviving beyond 5 to 6 years, doing very well. So, this is what has helped because of the advances in the molecular biology techniques that has helped us to have designer drugs to target these specific mutations. So similarly is another one called the ALK rearrangement. So this again, there is a specific drug which is also a tablet. Similarly, we have seen about 50 different gene mutations that have been identified, and for each one of them we have specific targeted drugs today. So these are the advances that we have seen. Of course, along with that, the supportive care has also developed very well. Some of the toxicities that the chemotherapy was producing was the bone marrow suppression, which decreases the production of all blood components, starting with red blood cells, white blood cells, and platelets. So today we have good component therapy for tackling these. We also have what is called as the colony stimulating factors, which can be given preventively to see that the bone marrow suppression does not occur. This is again important because a fall in blood count, decrease in the WBCs, can lead to infections in these patients. So that can actually delay the next cycle of chemotherapy that is being given and ultimately result in problems for the patient. So use of these supportive agents, the growth factors, the blood transfusions, and drugs to improve the platelet drop count. So these have made the patients very comfortable. So these are the targeted agents. I told you about chemotherapy, the anti-angiogenic drugs, the targeted agents, and the newest group of agents that we have got today is what is called the immunotherapy. So this is this very new group of drugs which actually works on the immune system of the body and tries to enhance it to fight the cancer. Cancer also produces certain substances which prevents the patient's immune system from taking care of these abnormal cells that occur in the body, which is called as the immune escape. So the checkpoint inhibitors or the immunotherapy acts by rejuvenating these immune cells to act against the cancer cells in the body. So we are combining these immune checkpoint inhibitors along with chemotherapy today to enhance the effect of both these groups of drugs. So these are great advances that have happened, and I'm sure this is going to continue further to improve the overall outcome of our patients of metastatic non-small cell lung cancer. So I hope this information is useful to you. If you want to have more information, you can join on the Lung Connect, or you can get in touch with me, and we'll be more than happy to give you all the information that you need. Thank you.